for the academic teaching for the PG students, which was, as you correctly said, it was went into the dormant phase. Initially, PAGE program used to run every month on Saturday, but that has like anyhow went into the dormant phase. But so henceforward, after 29, sir, it will be mainly focusing on the academic and PG teaching. That's the main agenda of that body, because all our IAP 2 bodies are already running, sir. And the intention of creating this chapter was only to focus on the neurology, and wherever help required for the PG student, we will definitely surely. That's where in this conference we are keeping one grand round in the morning of 1 hour, sir, and then quiz for the students. Our main agenda is to focus on the PG teaching, sir.
Thanks, Prashant. I think we'll start the PG clinics today. The setting is such, yeah, the settings have been made. Over to you, Sridhar, sir.
Yeah. I'm Dr. N.L. Sridhar, welcoming you all for this today's first PG clinic on 22nd January 2023. This is our first academic session. So I request now Garlapat Lakshman sir, our president, to say a few words. Sir, unmute cheskol, sir. Lakshman garu, unmute. రావట్లేదు సార్. వినపడట్లేదు సార్.
అన్మ్యూట్ చేసుకున్నట్లేదా? He did not unmute, it seems.
సార్ వినపడట్లేదు సార్. లక్ష్మణ్ సార్.
Dr. Sridhar garu, am I audible?
Yeah, you are audible, sir.
Okay.
I think Lakshman sir did not connect it to computer speaker or something.
He is not. He should be informed by phone, I believe. I think better we inform him by phone.
Yes, I'll do that.
ఇప్పుడు కనెక్టింగ్ టు ఆడియో.
Yes.
హలో.
అక్కడ కనెక్ట్ అవ్వలేదు.
అది
ఇప్పుడు వస్తుందండి. ఇప్పుడు కనెక్టింగ్ టు ఆడియో అని వస్తుంది.
అవునవును. లక్ష్మణ్ సార్ మళ్ళీ వెనక్కి వెళ్ళి రండి సార్. మళ్ళీ లాగౌట్ అయ్యి మళ్ళీ లాగిన్ అవ్వండి. రావట్లేదు సార్, వాల్యూమ్ రావట్లేదు సార్. మీరు ఫోన్ లో కూడా లాగిన్ అయ్యారు కదా, కొంచెం ఫోన్ లో మాట్లాడండి సార్. వినపడట్లేదు సార్.
No, he is not yet connected. Audio connect out.
హలో, ఇప్పుడు వినపడుతుందా? హలో,
ఇప్పుడు వినిపిస్తుంది.
Now you are audible, sir. Yes.
శ్రీధర్ ఏం చేశారంటే నాది మ్యూట్ చేసి పెట్టారు. నా సైడ్ నుంచి చేయడానికి రాదు.
అంటే ఓకే నా ఉద్దేశం ఇందాక అందరం
అక్కడ మ్యూట్ చేశారు. థ్యాంక్ యూ ఎవ్రీవన్. సార్ థ్యాంక్ యూ సుబ్రహ్మణ్యం సార్, థ్యాంక్ యూ రవికుమార్ సార్, థ్యాంక్ యూ ప్రశాంత్ ఉటాజే సార్, and welcome to young postgraduate Sharon Stephen with her two PG students Vaishnavi and Monica, and also I welcome Dr. Anusha, Sirisha and Dr. Prashant Utaje for this early morning first PG clinic program in the 2023. I hope this will be very useful for all the postgraduates And already there are 20-25 members have already joined in this program. I expect some more to join. And Ravi Kumar sir, please circulate these flyers to postgraduates in the future also, so that PGs will join in more numbers. And with this, I'll hand over to NL Sridhar to proceed the proceedings.
Thank you, sir. I welcome Central IAP EB member Dr. Nirmala Madam to this PG
Dr.
clinic.
Dr. Nirmala, good morning, madam. I missed you.
And I request Madam Nirmala Madam to say a few words. Madam, unmute cheskondi.
She is also, I think, co-host చేయలేదేమో.
But you have to unmute that.
Yeah. Good morning, all. Respected President, sir, past Superintendent Neelafar Hospital, Subramaniam, sir, and Professor Dr. Ravi Kumar Garu, and all the senior faculty and dear friends and colleagues. So PG Clinics is one of the main thing which we look forward to for all the PGs, as well as it's not only teaching experience for the students, but also for the teachers. From each and everyone, we learn at least a point or more during each of the PG clinics or any CMEs. So I wish all the best to the team Iaptcb led by Dr. Lakshman Garlapati Garu and Dr. NL Sridhar. Wishing you a very successful and year ahead and do more programs, and we are always there to support, and our postgraduates and our colleagues will definitely chip in. Yeah, thank you very much.
Thank you, madam. Thank you. I request Sunkoj Bhaskar sir, past president, who had done so many Zoom meetings since 4 years. Sir, Bhaskar sir, please.
Even during COVID season, he could conduct successfully.
Yeah. Thank you all very much. Thank you, Dr. Sridhar, for remembering me. But I'm sure this EB, which is very dynamic under the stewardship of Dr. Lakshman Garlapati and Dr. NL Sridhar, I'm sure you are going to do many more academic activities, many more charity services, and so on and so forth. I wish you all the very best, and my namaskars to all the seniors and to my colleagues. Over to you.
Thank you, sir. I request Sugunakar Reddy Garu, President-elect, to say a few words. Satish. Unmute cheyali meer anni
unmute cheyali andariki close chesanu sir.
Okay, sir. Sugunakar Reddy garu maatladandi.
Good morning. Good morning, Sridhar. Good morning, Dr. Lakshman. Good morning, Bhaskar sir. So welcome to the first official academic event of the year. So we'll hope that I hope a grand success for our team in this year 2023. I think we should not be less than Dr. Bhaskar sir and team.
Okay.
So hope this PG teaching program will continue in all the months and will continue successfully.
So, thank you, sir. Thank you.
Okay.
Ravi Kumar sir. Please. Hey, Satish, unmute cheyamma. Leda nannu host cheyi nenu unmute chesukuntanu.
Sir, అందరికి చేసి పెట్టాను సార్ ఆల్రెడీ. సార్ వాళ్ళ నుంచి చేసుకొని మాట్లాడొచ్చు సార్.
అక్కడ అన్మ్యూట్ అవ్వట్లేదు అన్న.
Unmute.
Hello. Yes. Yeah, ఇప్పుడు వినిపిస్తుంది సార్.
Yeah, because this particular case, no, actually we presented once, but again we brought this because so many new points we have missed in the first presentation. So I thought all these points should be shared with all our colleagues and my postgraduates, those who are visualizing. Definitely this is going to be, this is the rare case, but you know, urology part, it's very difficult to get those cases. Those pioneers, whatever the work they have done. So we've gone back to the history and taken back from 17 onwards, whatever the scientists has been done, how they could able to do this. So but all is going to be presented by my colleague, my junior, my postgraduate resident Sharul, and she has a special predilection for the neurology chapter. So she moved pillar to post to get the information, and I hope she's going to do very well. All the best, Sharul. And Vaishnavi is the first person who was there in the initial days of that case. Chalo, go ahead with both of you.
Thank you, sir. Now I welcome Dr. E. Arjun, sir, Central IAP EB member, to say a few words, sir.
Thank you, Dr. Sridhar and President. Hearty congratulations to the EB team, EB of 2023 for starting the academics on such a wonderful note. I wish you all the best for the next 1 year of academics. I hope it will be again a pandemic of academics like last year. And the able leadership of Dr. Lakshman, Sridhar, and RSV, I'm sure you all do a wonderful job and give back more awards than like last year. Good morning, Ravi also, our Pan India IAPN. Thank you all and all the best. Happy scientific deliberation. Thank you.
Thank you so much, sir. Now, today's coordinator is Dr. Sirisha, who is our EB member of 2023. And now I hand over to Dr. Sirisha. You can introduce our chair and moderator and experts and let them. Okay. Thank you. Sirisha, come on, please.
Good morning, all of you. Special good morning to all my seniors teachers on the platform. And happy to coordinate today's first 2023 Iaptcb academic session. And today we have two experts to give their valuable inputs to our postgraduate students. Well-known Dr. GVS Subramaniam sir, one of the most renowned pediatricians from Hyderabad. Sir is former professor and superintendent of Nilupur Institute, and is a teacher for hundreds of pediatricians like us, and he has a vast interest in medical teaching, public health, vaccinology, and developmental pediatrics. And another expert is Dr. Prashant Tutage sir, one of the leading child neurologists specialized in cerebral palsies, epilepsies, ASD, and ADHDs, and with so much of social service also, and with nearly 1.5 decade experience. He is one of the renowned neurologists in Hyderabad and owner at Utage Child Neuro Clinic and Development Center. Sir, pleasure to have you to guide our students today. And today's case moderator is Dr. Ravi Kumar sir, professor and former HOD at Nilupur Institute of Mother and Child Health. And we have our senior postgraduate, Dr. Sharon Stephen, who is presenting this neuro case. And sir, can we have few valuable words from Dr. GVS Subramaniam sir and Prashant sir? Over to you, Subramaniam sir.
So I congratulate the entire new team of Iaptcb for having taken initiative of PG Clinics. That means they are continuing the mission with which they want to enthuse young postgraduates in terms of developing their clinical skills. And I'm sure the postgraduates will make use of this platform to develop or refine their knowledge and skills. And I am thankful for all the executive members and also my co-hosts and others, and Dr. Prashant, especially my co-host, for allowing me to participate in this. Thank you very much.
Thank you. Before I go ahead, I want to thank my teacher, my respected Professor Alladi Venkatesh, because of whom I am on as a pediatrician and trained under him at Durgabai Deshmukh Hospital. And congratulations to new AB, and good morning to all respected seniors. So we'll try to contribute whatever possible from our side in the neurological aspect. Thank you, thank you, everyone.
Thank you, sir. Sridhar sir, can we proceed?
Yeah. Please, you can.
Sir, can you share the PPT, sir?
Sharon, you can share the PPT and you can start.
Yes, sir. Yes.
Morning, sir. Is it visible, sir?
Yes.
It is visible, Sharon. You can. All the best, Sharon. You can start.
Thank you, sir. A very good morning to all the faculty and my colleagues. Myself, Dr. Sharon Stephen, final year postgraduate from Nilafur Hospital, presenting a case. 11-year-old male child brought by mother to Nilafur Hospital with chief complaints of paucity of right upper limb and lower limb movement since 4 years of age. Seizures involving right upper limb and lower limb since 14 months. Child has paucity of movements in the right upper limb and lower limb. Paucity is observed by the mother when the child started to walk at 4 years of age, which is associated with stiffness while dressing and bathing the child. The child is able to lift both the arms above the head and take objects from a height. The child is having difficulty in mixing food while using the right hand. He uses his left hand for daily activities like eating and dressing. The child is able to lift his head from the bed. He is able to get up from supine position. History of difficulty in climbing up and down the stairs. He climbs by using 2 feet per step. History of dragging of right foot while walking, and history of difficulty in walking with slippers held in the foot. Coming to the seizure, there is history of seizure on the right side with tonic posturing of both the right upper limb and lower limb with deviation of eyes to the right side, not associated with frothing, with no bowel and bladder incontinence, no residual weakness. Initially, it was thrice a month, but the frequency of episodes increased to 3 episodes per day, each seizure episode lasting for 2 minutes. Child is gaining consciousness immediately after the seizure activity. There is no history of fever, ear discharge. There is no history of perception of heartbeat, bluish discoloration of tongues and lips, easy fatigability. There is no history of pain abdomen, yellowish discoloration of skin, pain in hands or feet, or bone pains. There is no history of loss of speech. There is history of early left hand preference. There is no history of abnormal smell perception or loss of smell. There is no history of blurring of vision or vision disturbances. There is no history of abnormal positioning of eyes, head tilt and drooping of eyelids. No history of sensation loss or abnormal sensation over face. No history of drooling of saliva. No history of collection of food in the mouth. No history of difficulty in chewing of food. No history of difficulty in closing eyes or watering from eyes. There is no history of loss of taste sensation. There is no history of any hearing abnormality. No history of difficulty in perception of hot and cold water. There is no history of rapid eye movements, no history suggestive of involuntary movements, and no history of excessive or reduced sweating, no history of bowel and bladder disturbances, no history of vomiting and headache, and no history of nuchal pain. Sir, shall I continue, sir?
Just wait. See, you said can you list out the complaints which you have mentioned earlier? Just get back to that slide.
Yes, yes.
So, just at 4 years the problem has started. Yeah, am I right?
Yes, sir.
So at 4 years, and you have made a mention about seizures also.
Yes, sir.
But you did not specify when the first seizure episode has been noticed by the parents.
Sir, at 14 months of age, before past.
So 14 months of age. 14 months
no, sir,
of
past
age.
14 months, sir.
14 months of age.
No, sir, past 14 months.
Past 14 months only, child is throwing seizures. Okay.
Yes, sir.
That is at the 10 years.
Just because it is coming in the way of reading the slide, because you are, I will reduce this. Okay. Okay. So since 14 months of duration only, the child is having seizures. Am I right?
Yes, sir. Means the child was around 9.5 to 10 years, sir.
Okay. So only the seizures were involving only right upper limb and lower limb only. Focal seizures.
Yes, yes, sir. Focal seizure with impaired awareness.
Okay. So therefore, your entire present history spans from 4 years of age. Right now, the child is 11 years. That means the present history should, what has happened in this 7 years, you will try to describe. Is it not? The seizures were there since 14 months and they were focal seizures. Anything you have mentioned so much of negative data. I understand the reason behind, but for the sake of postgraduates who are attending this, can you tell what is the relevance of that negative data which you have elicited?
Yes, sir. For the first negative history, there's no history of fever or ear discharge, trying to rule out any infective cause of this present seizure. And there is no history of any perception of heartbeat, blues discoloration of tongue and lips, and easy fatigability. It is to rule out any cyanotic congenital heart disease. My keeping in consideration the paucity of upper and lower limb movements, we are thinking of any hemiparesis. So the negative history will be based on, will help to rule out the etiology step by step. So any complex congenital heart disease is there or not, which there is no history of pain abdomen, yellowish discoloration of skin, pain in hands or feet or bone pains. It is suggestive of sickle cell anemia. And there is no history of loss of speech, that is for higher mental function, involving the Broca's area and Broca's area. History of early left-handed preference is there, sir, in this patient. No history of then remaining all the negative history is for the cranial nerve examination, which is no history of abnormal smell perception, no history of blurring of vision, and no history of abnormal positioning of eyes, head tilt and drooping of eyelids, that is ptosis. No history of loss of sensation or abnormal sensation over face, that is trigeminal nerve. No history of drooling of saliva, collection of food, difficulty of chewing or closing of eyes, that is of the facial nerve palsy. And even sensory part is no history of loss of taste sensation. Eighth nerve, no history of any hearing abnormality. For sensory sensation, we have asked for no history of difficulty in perception of hot and cold water. For nystagmus, we have asked for cerebellar signs. We have asked for no history of rapid eye movements. And for any involuntary movements involving the basal ganglia, we have asked for no history of involuntary movements. And for autonomic dysfunction, we have asked for no history of excessive or reduced sweating or bowel and bladder disturbances. For asking for raised intracranial pressure signs, we have asked for no history of vomiting, headache. And for meningitis, we have asked for no history of nuchal pain.
But in this case, do you feel raised ICT sign has to be ruled out in this case?
Sir, if there is any new onset, sir, for the seizure part, we have to rule out because the frequency of the seizure increased, sir. It became 3 episodes per day.
Dr. Prashant, sir, can you ask your question once again? It was not a bit audible for me.
Usually what happens now, all negative history has to be mentioned. But in this case, what she is justifying is, means it is in a acute cases, history of vomiting and headache is applicable. As this is a chronic case, that is the clear cut, we can see there is a hemiparesis right side and then started seizure 14 months back. So I was just asking her, is it applicable to this case to mention the vomiting and headache? That's it, sir.
Sir, if it is a case of, suppose if you are thinking any space occupying lesion, and if there is a, if there is any hemorrhage in the tumor, or then there can be raised intracranial pressure, sir.
Yeah. So it is a acute, sudden vascular stroke or any raised ICT secondary to encephalitis, a kind of thing, or any SOL if you are suspecting, definitely is required. Any other history of any knuckle pigmentation did you mention? Hyperpigmentation of the...
No, sir.
So what is the significance of this?
Vitamin B12 deficiency will have hyperpigmentation of the knuckle, sir. It is one of the treatable cause of ataxia.
Is there ataxia in this child? Hello?
No,
is
sir,
there ataxia in this child?
No, sir. There is no ataxia, sir.
So before we go on to that, just I wanted to ask some questions. See, there is a weakness on the right side involving the right upper and lower limb. Is
Yes,
it
sir.
not? And
Yes, sir.
you also made a mention about child having some degree of stiffness. Is it not?
Yes, sir.
Also was there?
Yes, sir.
As the child is making sometimes the parents will tell, sometimes you can elicit the stiffness also. So therefore, if stiffness is there, weakness is there, one semi weakness is there on the right side, that signifies possibly, as sir said, right-sided hemiparesis or hemiplegia. Is it not? So
Yes,
if that were to be the case, we should try to see if one half of the weakness is there. Usually, what will be the where will be the there are 2 points, 2 objectives in history taking in neurology. One is to identify where the locus is, where the
yes, sir.
basic problem lies. Number 2 is to find out what could have caused that problem. Is it not?
Yes,
So,
sir.
one is location, 2 is etiology. So the mode of onset, the progress or the evolution of the symptoms over a period of time will give us clue regarding the etiology. Of course, history-wise also we can try to find out the location. History-wise.
Yes, sir.
In this case, history is positive movements on the right side and associated with stiffness of the limbs. And you said there were seizures also. The focal convulsions since 14 months. Is it not? So if the focal convulsions are there, where is the probable site of lesion? What you can think, where it can be?
Taking the history into consideration, sir, this is like a chronic, the issue is a chronicity is there.
Yes.
And about the anatomical localization, it will localize to the left cerebral hemisphere, sir, left sided, because the lesion is because the manifestation is in the right sided hemiparesis is present with right sided focal tonic seizure with impaired awareness.
Okay. So because the weakness is on the right side and is dense, involving one half of the body, possibly you are postulating a lesion in the left cerebral hemisphere.
Yes.
So if that were to be the case, and it is accompanied by seizures also, where do you find seizures as a clinical phenomenon, where the lesion could be?
It will be in the cortex, sir.
Good. So therefore, when cortical symptoms are there in the form of seizures, and there is associated weakness also, we have possibly postulate a lesion in the left. As far as the anatomical localization is concerned, that much. Then, as you said, it is a chronic one, which has started as per the notice of the parents from the age of 4 years onwards. I think we need to get back into the details of what has happened prior to 4 years also, that you may tell in the past history. But right now, the parents have noticed the positive movements from the 4 years of age. Is it not?
Yes, sir. Yes, sir.
That was the thing. So what other things would be pertinent to find out what could have caused the problem? You mentioned about where, okay, tell.
Yes, sir.
What could have caused the problem at the age of 4 years? How was the onset like?
Sir, the history is like, sir, I would like to go to the antenatal history, birth history, sir, because that has significance.
Okay.
Shall I proceed, sir?
Okay, you continue then.
Or would you like to elaborate the same history?
Subramanian sir.
Chappan.
Sir, Amine adite Amine telusu sir.
Chappan.
She knows all the points, sir. Because
okay.
Because you are just revealing the question paper. That's all. You ask somebody who can interact.
Past history. Sir, past history, there is no history of any TB contact, no history of blood transfusions, and there's no history of any exanthematous rash. The family history, there is no history of any seizures. There's no history of any history suggestive of any family member who is physically disabled. There is no history of any bleeding disorder, stroke, sudden cardiac deaths in the family. Child is born out of second-degree consanguineous marriage and second in birth order. The birth history, the mother was married at the age of 18 years with second pregnancy conceived at 22 years of age. She was a registered case, received regular antenatal checkup, received TT and iron and folic acid supplementation. There is no history of fever with rash. There's no history of burning maturation. There's no history of poly or oligohydramnios, gestational diabetes, hypertension, or thyroid disease in the mother. Natal history, which is significant. Term baby, child was born by normal vaginal delivery in the ambulance, and at the time of birth, child sustained head injury, for which no active intervention was done. Child cried immediately after birth, and the birth weight of the baby was 3 kgs. The child was postnatal. In the postnatal life, the mother noticed icterus in the baby from 9th day of life. On 15th day was admitted in the hospital in view of neonatal jaundice. An exchange transfusion was done. During the hospital stay, a neurosonogram was done at 30 days of life, which showed left subdural hematoma, for which neurosurgery opinion was taken and there was no active intervention needed. Developmental history, the development of the child is the gross motor, all the domains are delayed. In the gross motor, the child currently can walk only upstairs and downstairs 2 feet per step. The DQ of 45%. The fine motor, the child is able to scribble and only hold scribble with the help of left hand. The DQ is 25%. Social and adaptive milestones, the child plays cooperatively in a group with his DQ of 44%. And language, the child is able to say a vocabulary of 8 to 10 words, with DQ of 20%. The total development quotient of the child is 33.5%.
So this child is then delayed from beginning, but observed by the parent at the age of 4 years, right?
Exactly, sir. The DQ of 33.5% suggestive of global developmental delay, since all the domains are delayed. Immunization history, the child is immunized till 5 years of age as per UIP schedule taken at the local PHC. Nutrition history, according to calculated by 24-hour recall method, the calorie deficit of 122 kilocalories and protein deficit of 2 grams. Socioeconomic history, the child belongs to lower middle class according to modified Kupaswamy scale. General examination.
Wait, I think it is time now for to summarize the whole of the important points in history.
Yes, sir. 11-year-old male
child was born in the ambulance, is it not? It was something like a precipitate labor, and you have made a mention about head injury. So what was the description that was told by the attendants? Because I understand they are lay people, they may not be able to tell. And what was the condition of the child?
Sir, the mother, what she told that the previous evening of the night of the day of the delivery, the mother started having labor pains by around 6 p.m. and by next day evening by 6 p.m. the mother delivered on the way to the hospital. During the delivery, the child fell flat, sir, actually flat and on one side. That's what that description is, not more, sir. Which sustained head injuries, what the mother told. Sir, I did not get your question, sir.
So the child, why the child had got siblings, you said, is it not?
Yes, sir, siblings.
But they did not notice any developmental delay up to the age of 4 years. Most of the times what happens is, if there are siblings, usually the index child will be compared with that one of healthy children, and mother tends to identify the problem much earlier than what it was, like 4 years. What caused this delay in identification of the symptoms by the parents, especially when siblings are there who are otherwise healthy?
The mother, what she says is, after the neonatal life, by around 6 months, they noticed that the baby was having more excessive sleep, and the child used to not have that interaction, was not that active like that of the first child, sir. They have just taken to a local PHC, that's all, sir. They have never evaluated further. Even at 2 years of age, when the child was not even able to stand with support also, that time also they have carried the child everywhere, wherever they traveled, sir, is what the mother told.
So can you, for the sake of postgraduates, can you enlist what are the early markers a child of that type can have, such that there is a scope for early intervention also? What are the early markers by which a child can be identified? Because child may come for routine immunization or for any healthcare visit. Such a case, the problem needs to be identified earlier. What are the usual early markers? Even routine examination also will reveal, based on the child's posturing or whatever it is. What are the usual early markers?
Yes, sir. Initially, there can be excessive cry, inconsolable cry can be there. There can be even refusal of feed can be there by the thrusting of the tongue by the baby. The baby can also, the tone of the baby can be assessed. The baby can be floppy infant or it can be stiff baby, where the mother can have difficulty in changing of diapers. And the child, the development of the child, there will be a deviation. Means a child will try to attain certain milestones before attaining the other milestones. Like the child will be able to stand before crawling, or before sitting. Sorry, before sitting. So that will be suggestive of spasticity of the lower limbs. And even the early hand preference. The child will usually, the mother in these type of children, they will be with less than 2 years of age. They will be early hand preference. So these all are, and even suppose there is a spasticity in the lower limbs, then the child can also have like a commando crawl. Other signs are
majorly, did you mention head size? That is the first thing we need to mention actually when we are dealing with any case of developmental delay. The head size.
Yes, sir.
That is very, very important, because that we usually start from head to toe. Rest of the same, like whatever you have described is good, but usually we should mention it is a normocephaly or microcephaly, macrocephaly, that gives a major direction to the case.
Yes. Usually in this type of children, there is microcephaly, sir.
So what is in your case?
Microcephaly, sir.
Okay. How much standard deviation below like?
Sir, it is less than first standard first centile, sir.
Okay.
This child had immediately after birth, child was well. This child.
Yes, sir.
As per their version, and head injury was sustained at the age of 15 days or what? 15 days?
No, sir. At birth only, sir.
At birth
during delivery.
And what? No interventions were done.
No, sir. No intervention was done.
Baby was breastfed or what? Were there any feeding issues?
Baby is breastfed since birth only, sir. According to mother, there is no feeding difficulty.
No difficulty. So when exactly the first problem was noticed?
At 9 days of life, mother noticed icterus, sir.
Okay.
So for and 15th day of life, they have come and they've got admitted.
Yes.
That time it has been treated by exchange transfusion. During the hospital stay, we have done a NSG, which
because of some. I'm overhearing some other talk. I'm sorry. You please. Yes. At 9 days, baby had jaundice. What happened then?
At 9 days of life, mother noticed icterus, sir. So that mother came to hospital at 15 days of life.
Okay.
And that time the blood investigation was done, and that was in exchange range, and so the child underwent exchange transfusion.
Okay. Then what happened?
Then during the hospital stay
Sir, overhearing one more thing, sir. Unmute.
Hello, sir.
Audible. Proceed.
Sir, so during the hospital stay itself, when they took the history, there was a head injury. So neurosonogram was done. That report showed that there is a left subdural hematoma.
Very good. Okay. Right.
Even for that also, there was no active intervention done, sir. They were advised for a follow-up, for a monthly follow-up up to 3 months, sir, for the resolution of the hematoma.
Okay.
That was also not done by the parents.
So did not come for follow-up?
No, sir, they did not come.
So did they notice any increase in the size of the head at that time?
No, sir.
No such history is available. Okay. So chronic subdural hematoma can be there. Bridging subdural veins could have ruptured, could have caused some hematoma, which can act like a slow space occupying lesion that would have caused. Usually, if the parents are observant enough, they may identify increase in the size of the head or bulging. For some observant parents may tell, but they may not tell. But in the instance case, the child was discharged and no intervention was done at that time. So possibly the very point child had jaundice may be due to intracranial bleed also. That also we have to keep in mind. because knuckle bleed somewhere in the cranium also can cause jaundice, and it has gone to the level of extent, and our people have done it right. Okay, then okay.
Dr. Subramaniam sir, with your permission,
Can
I ask the question to the presenter, Sharon Stephen?
Sure, sir.
Sharon,
Yes, sir.
what was the birth weight that not mentioned?
3 kg, sir, mentioned.
3.5 kg, sir.
Was there
3
any stigmata of the torch infection?
No, sir, there is no history of
Stigmata
fever.
the torch, because
No,
we
there
are
is.
telling the microcephaly and subdural hematoma and jaundice. Was there any critical rash, hepatosplenomegaly?
Sir, Anand sir, child was something like a precipitate labor. She delivered in the ambulance. There was a history of head injury. Child was noticed to have jaundice on 9th day and was done external transfusion on 15th day. Subsequently, child's condition, no intervention was done, and not the parent did report for follow-up. That is what the history she has given. So in this case, there is a need for inquiring about torch infections. May not be much, sir, but because there is a clear-cut case of precipitate labor with head injury at birth.
The chronic subdural hematoma.
Bleeding inside the cranium, that could have caused the jaundice also, and that would have raised the bilirubin levels also.
It was more of indirect hyperbilirubinemia.
Chronic subdural hematoma may cause that. So, okay, thank you.
So therefore, that point is also important, but okay. Amma, Sharan, you please continue. So 30 days of life. So you said the speech was normal. Is it not? Speech was normal. You said
No,
it
sir.
was,
Currently normal, sir, but it is delayed.
it was delayed onset of speech was there.
Yes, sir. Delayed onset of speech is there. Even now also, child cannot sing rhymes, sir. He can only say a vocabulary. Vocabulary of 8 to 10 words are there. Sir.
Okay. So at what age child started speaking?
Child started speaking monosyllables by 5 years of age, sir.
5 years of age. Till then, child did not speak.
No, sir.
To my surprise, even then the parents did not bother to take the child. Then the child was not able to speak up to the age of 5 years, in spite of having siblings also. Okay. Right. So there was right.
Yes, sir. This looks like a more of a global developmental delay. Even the history says there is a hemiplegia, like a right hemiplegia, but on DQ, if you see, he is delayed in almost all every area.
Yes. Once there could have the child, because had hyperbilirubinemia also, we don't know whether the child's hearing and other things that could have caused the delay also.
Yes.
So we have to keep in mind there is a history of delayed speech in this case, and the speech is Dr. Sharan, his speech is now intelligible speech. Meaningful words child is able to utter.
Yes, sir. Yes, sir. He is able to respond to whatever we speak, and there is meaningful words, sir.
Meaningful words, and he is responding to verbal commands. He is able to comprehend your speech.
Yes, sir.
Okay. Right. Okay. Continue. Right.
Yes, sir. Coming to general examination, child is conscious, lying on bed.
But for the sake of, in general, I am telling, when the child is presenting itself with a history of hemiplegia on the right side, in this case, it is quite obvious. There is a possible left cortical lesion, or it may be a subcortical or a capsular lesion. If that were to be the case, if there is a dense hemiplegia, it is more likely to involve the internal capsule, because the whole half of the body gets involved. But if there were to be other evidences of formal cortical deficit are there or not, also we have to inquire symptom wise. Similarly, we need to find out whether there is any sensory disturbance, because if it were to be capsular lesion, there can be a sensory disturbance also. So most of the times hemiplegia is associated with hemianesthesia and hemianopia. So if that were to be there, if in the case of a older child, you can inquire about any sensory disturbances that were to be there, and also regarding any visual disturbances, something like patient ignoring on one side of his, when the examiner approaches from one side, he may not be able to notice. So if such history is there also, you can inquire in older child if symptoms were to be there. Okay, right. General examination.
Sir, child is conscious, lying on bed, adduction at shoulder and flexion at the elbow and wrist joint with extension of the digits. Right cortical thumb is noted. Right lower limb extended at the hip and knee joint, plantar flexion of the foot. No pallor, ictus, clubbing, cyanosis, colnoidal or edema, no significant lymphadenopathy. Vitals temperature 98.4 degree Fahrenheit. Pulse rate is 104 per minute in the left radial pulse, which is normal in volume and character. Regular rhythm and other peripheral pulses are felt. No radial or radiofemoral delay. Respiratory rate 28 per minute, regular. JVP is normal. Blood pressure is 100 by 60 mm of mercury, recorded in the left arm supine position, and there is no postural variation.
Here a few points about vitals. So whenever temperature, okay, it's the pulse rate, and most importantly in CNS, peripheral pulses are also very, very important. So there may be delayed and diminished femorals, as in case of coarctation, you have to look for. And when the patient is presenting himself with a stroke, himself or herself with a stroke, you need to look for carotid pulsations also. Sometimes you may come across even carotid bruits and other things. Therefore, you have to examine carefully carotids one after another. Both carotids simultaneously should not be palpated. So respiration, of course, rate and rhythm, you just observe just like any other thing. Regarding blood pressure also, it would be better for a postgraduate to record the blood pressure in all the four limbs. It's not only one limb, and whatever may be the size of the cup, that is now with the NIVP being available, you can measure all the four limbs, right? Okay, continue.
Okay. Anthropometry, the weight is 21 kgs. It comes under 3rd to 10th centile. According to IAP classification, he comes under grade 3 protein energy malnutrition. Height, it is 132 centimeter, 3rd to 10th centile. Body mass index is 12.3 kg per meter square. Head circumference is 44 centimeter, which is less than the first centile, with inference is microcephaly.
So if the head circumference is more than how many standard deviations, you call it a microcephaly?
So if it is
more than how many SC?
Less than 3 standard deviations.
Ah, good. So if you want to say pathologically microcephaly, the head size should be more than 3 standard deviations below the mean value for the age and sex, right?
Yes.
Yes, right.
Head to toe examination, microcephaly is present. There is no changes in hair or hair loss. Ears, eyes, nose are normal on examination. Dental caries are present. No oral ulcerations, chelosis or glossitis. No chest deformities. Cortical thumb is present. Genital is normal. No skeletal deformity. No contractures or neurocutaneous markers. No signs of vitamin deficiencies.
Did you ask the mother, child was having the thumb in the adductor position right from early childhood onwards? That was there before also?
Yes, sir. It was noticed by the mother.
By the parents. So you could have mentioned it in the past also. That would have thrown, that would be a better historical description of the child. Okay. So you have made a mention about the microcephaly. I could see the child, right? So that's good. And one more point here is, especially in clinical presentation of neurology, whenever you wanted to make a presentation, better do you have a video recording of child's gait also?
No,
that would because that would serve a better purpose, because we are most of the times we are not seeing the patient live here. We are only seeing virtual. So better would be to have a small video clip of child's gait. Suppose any gait disturbance is there, how the child is walking, and if there are any abnormalities, that also can be, we also can understand something much better. Okay, that's right. Okay. Sir, Prashant, sir, you want to add something? Head to toe.
Yes, sir. Like head to toe, do you feel any mention of dysmorphic features we need to do in this case?
Yes, sir. We need to, sir.
So what are those, like particularly?
If the child is having any low set ears, or the child is having any mongoloid slant.
Significance? You mean to say it is a Down syndrome?
Yes,
so
sir.
What significance, like what do you think of, like when you think Down syndrome? Are they prone for any particular condition where they come up with?
Down syndrome is Moyamoya syndrome. Moyamoya, which is a vascular cause of the stroke. It is associated with few syndromes here, like trisomy 21 and with neurofibromatosis type 1.
Even in this, along with dysmorphism, we need to mention the neurocutaneous marker in this in general examination.
Sir, I have mentioned, sir, second but last line. No neurocutaneous marker, sir.
You have mentioned in this neurocutaneous markers? Yes. Last but second line. Okay. So that you have, by default, you can make a mention about it. So evidence of any facial dysmorphism, evidence of any micronutrient deficiency, the presence or absence of any neurocutaneous markers, these things you can make a mention. And general observation about the child's the stance, the posture, everything, you can make a remark about even the movement also in the general physical examination.
Okay, sir.
So this child, as you can see, is keeping his right lower limb a little away. So, and hand also he keeps always in this position. Is he keeping?
No, sir. Actually, it is this position. But then when we were taking a, sorry, sir, it is it could have been a better image. But when we were taking pictures, the child extended it.
That's not a better image or something of that sort. What is the usual stance and the what was the actual posture of the child in general, as you would have observed much longer time than us?
Yes, sir.
So therefore, was there any something which is peculiar that needs to be mentioned? That
Yes,
because
sir.
the posture reflects something more about the child's condition. That's all.
There was a right-sided hemiplegic stance, sir. Like the child, the shoulder was adducted and the elbow was flexed, the wrist was flexed, and the
elbow is flexed here little. Okay.
Is he bearing weight equally on both the lower limbs or taking the support of one limb?
What is his stance like? He is bearing more his weight on his left leg.
Yes, sir.
He is taking the foot off the left leg. That is also an important. Even this photograph conveys some message. That's what I personally feel. And child is keeping his hand in the prone position. Is it not?
Yes, sir.
Okay. Right.
Okay. I would like to start my clinical systemic examination by starting in the central nervous system examination. High mental function. Child is conscious, oriented to time, place, and person and self. Speech, vocabulary is limited. Speak sentences of only 3 words. Intellect, thinking, reasoning, attention, and calculation is impaired. Memory, immediate and short-term memory is intact, but long-term is impaired. And he is left-handed. Cranial nerve examination. First nerve, olfactory nerve, able to perceive smell. The second optic nerve examination, the right and left, it was normal in terms of visual acuity, visual field, color vision, and pupillary reflexes were also normal. Fundus examination was normal. 3, 4, 6, there was no ocular movements, which was normal and similar in both the eyes. Fifth cranial nerve examination, the sensory part, the child is able to perceive pain, touch, and temperature over the forehead, chin, and cheeks. The motor part.
Did you test?
Yes, sir. I have tested. The child has also told.
Okay, you have tested corneal and conjunctival reflex also.
Yes, sir.
Okay. So
what is the gait of the child?
Sir.
Hello?
Gait of the child. Gait.
Sir, I have written that in motor examination, sir.
Motor examination. Okay. So here child was having all sensations being intact. In the fifth nerve also you mentioned. He is responding to your verbal commands and is able to clench his teeth and open his mouth as and when you command him.
Yes, sir. He is able to, sir.
He was doing so without any SMS. Suppose if there is paralysis, usually paralysis of the muscles of the mastication will lead to what?
Muscles of mastication paralysis will lead to child will. Sir, same side deviation.
Jaw will deviate or not? One side there is a paralysis.
Sir, same side deviation.
What are muscles of mastication?
Sir, buccinator and pterygoids or medial and lateral pterygoids.
That's all.
And frontotemporalis.
Frontotemporalis.
Sorry, sir, temporalis, sir.
Temporalis. So the temporalis, masseter, and also medial and lateral pterygoids and digastricus muscle. So if the muscles of the mastication are paralyzed, jaw will be deviated towards which side?
Same side, sir.
Same side, right. Okay. So therefore, usually the motor route accompanies the mandibular route. So therefore, it supplies the muscles of the mastication. You can ask the patient to clench his teeth and feel for the temporals as well as the masseter muscles. That you can feel. Right. Okay. Continue.
Seventh cranial nerve examination. The child is able to frown and raise his eyebrows. The child is able to close his eyes tightly. There is blowing of cheeks, which shows about the intactness of buccinator muscle. The nasolabial fold is also present in both the sides.
In this particular patient, if there were to be a facial weakness, on which side we expect facial weakness? Right side or left side?
Sir, it would have been the contralateral side to the lesion, sir. So this would have been palsy would have been on the right side only. Right side of the face.
Right side only. Why?
Since, sir, it is a UMN type of lesion.
Yes.
Of the seventh cranial nerve.
Yes.
So that will involve the lower half of the contralateral side of the, means from the lesion contralateral side, sir.
Very good. So therefore, if UMN facial palsy is there can be weakness involving the right side of the face along with weakness of right upper and lower lips.
Yes,
but
sir.
Since being UMN weakness, it involves only the lower part of the face. The upper part of the face may be spared, such that the child will be able to blow, or he will be able to blink, or he will be able to frown. Is it not? But here the child is, so sometimes minimal facial weakness also may have to be identified. Suppose that happens because minimal facial weakness is maybe in the form of slight asymmetry in the nasolabial fold. That may not be very blatant, and one needs a keen observation. But most of the times, the facial weakness, if that is present, that is all the more evidence that probably the lesion is in the level of internal capsule. Right? Okay. Right.
Sensory, the taste over the anterior 2/3 of the tongue is normal. Secretory function.
How did you test for sensory taste? How did you test? Did you test?
Sir, I've tested, sir, but the child could only perceive, could only say about sweet, sir, for me while testing.
Okay. You tell whatever you have done, that only you tell. Right. Okay.
Yes, sir. Very difficult to elicit the test sensation.
That is because the examiners will have something. They may question why, when you have not tested, why you say it's normal and all. So better, sir, I could not test this, or the child could respond only to sweet sensation. Whatever is there, you tell. Okay. So there,
Yes.
we can understand in the case of especially assessment of sensory system in children, more so when the child is inarticulate and is not able to express subjective symptoms, there are limitations in history taking. We can understand. Okay. Hello. Am
Yes,
I
sir.
audible?
Yes, sir. Yes, sir. I'm listening.
So therefore, what I suggest to you, young postgraduates, is whatever is feasible, whatever is permissible, whatever the child can express, that alone you tell. Otherwise, you simply say, I could not test further, sir. There's nothing wrong about it. So as far as sensory system is got, there are limitations in pediatric neurology, right? Okay, continue.
The child was having lacrimation was present, sir, and lacrimation salivation was present. Reflexes, the corneal reflex was present in both the eyes.
So corneal, what is the afferent? Corneal reflex. What is the afferent for corneal?
Fifth cranial nerve is
efferent. What is the efferent?
Seventh cranial nerve, sir.
Good. Right. Continue. Right.
Eighth nerve examination. Hearing was hearing. We have only done Rennie's test, sir, for this child.
Okay.
9th and 10th nerve gag reflex was present and symmetrical. Palatal reflex was present. 11th cranial nerve, no wasting or drooping of shoulders. The child is able to turn head to both sides, and child is able to shrug the shoulders. 12th nerve, the bulk of the tongue is normal, no deviation of the tongue, and no abnormal movement seen in the tongue.
Yes, sorry to interrupt. 8th nerve auditory function, how did you check it in this child?
Sir, only we use the Rennie's test, sir. Rennie's
in such child where they are not cooperative, especially when the cognition or DQs of 33.5, simply you can tell if you call him by name and his turning itself is like sometimes, because very difficult when there is cognition is down to interpret all these tests, Weber's and Rennie's.
Okay, sir.
So coming to this particular case, a child who had severe neonatal jaundice and has received exchange blood transfusion, the possibility of 8th nerve damage is also quite likely. So therefore, hearing might have been impaired. So there are that also we have to keep in mind, right?
Yes.
Okay. That could have caused delayed speech also, right? Okay.
Yes.
Motor system examination. Posture, the child was comfortably lying on bed. Adduction at the shoulder and flexion at the elbow and wrist joint with cortical thumb was noted. Right lower limb extended at the hip and knee joint. Plantar flexion of the foot. Bulk of the muscle On seeing, there is no visible wasting, sir, but on a measurement, there was wasting present in the right upper lobe and limb and lower limb. Tone was.
Wait. So, when you close the right lower limb, extend hip joint is plantar flexion. Bulk of the muscles wasting is present right upper and lower limb. So you could identify by taking the measurements from a fixed bony point. Huh?
Yes, sir.
Is it? So you have
Yes,
taken
sir.
a standard reference bony point. From there, you measure the mid-arm circumference and say that there is a wasting. That's how you need to confirm. Is there any difference in the limb length? Limb length discrepancy have you noticed?
No, sir, there is no limb length discrepancy in this child.
Because this child is 11-year-old and the problem, at least as per the parents, has started around 4 years of age. And with the 7 years history, usually there can be some degree of limb length discrepancy also. Is it not?
Yes, sir.
Did you measure the limb length? Did
I
you
measured, sir.
both the limbs were of same size in terms of its length?
Yes, sir. I have measured from A
But
size.
you must remember, in long-standing cases, there may be difference in the limb length also.
Okay.
Because of course, LMN is more severe in terms of causing influence on the length, but UML lesions also, long-standing lesions, can interfere with the length of growth of the limb. So therefore, if any limb length discrepancy is noticed, that should be mentioned in anthropometry as well as in the motor system. Right. Okay.
Tone in the upper limb, right-sided upper limb and lower limb tone is increased. Left side it is normal. Power.
No. Tone is increased. You said is a older child. So what are your remarks about? So you say there is a hypertonia.
Hypertonia, sir.
Hypertonia is there. Agreed. So you said the limbs were stiff according to the parental observation also. Apart from paucity of the movements usually denote a decrease in the muscle power. Is it not? If the limbs are stiff, that reflects something about the tone of the muscles. Is it not? The parents said. And on your examination also, you came to know that the child is having hypertonia on the right side. So what are your further comments about that hypertonia? The hypertonia was there throughout the movement, passive movement you have tested. What are the ways in which you have tested for the tone? First.
We can do by passive method or
what you have done?
Sir. Log roll method, sir. Where I have
what are the
I've held the arm of the child and the wrist of the child. The moment at the wrist level has been forearm of the child, and the moment at the wrist level has been noted, and the leg of the child, the leg of the child has been rolled over the bed, and we've seen the moment at the ankle joint, sir.
In other words, you have tested for passive movements and observed whether there is any resistance to the movement or not. Is it?
Yes, sir. Yes,
so,
sir.
Is there any difference in the resistance? Was it uniform throughout, or was there any comment you wanted to say during flexion and extension? Same degree of resistance, or what? Or is it more?
No, sir. During flexion and extension, during the start, there was some resistance was there, and then as we kept when the complete flexion was done, then there was no resistance.
So that means there is some release. Initially, some resistance is more, and there is a sudden release. What is that called?
Clasp knife spasticity.
So where do you get this clasp knife type of spasticity? Which condition?
In pyramidal tract lesion, we will get the clasp knife spasticity, sir.
Both upper and lower limbs, you could make out clasp knife spasticity here.
Yes, sir.
So
yes,
what is the other hypertonia you come across in clinical practice?
Another type is rigidity, sir. Rigidity will not be velocity dependent. It will affect both the agonist and antagonist muscles. It shows the thing of extrapyramidal tract lesion, sir.
Okay. So if the rigidity is there, that suggests EPS or extrapyramidal system involvement. That is what you wanted to know. In this case, there is no rigidity as you could make out.
No rigidity, sir.
Right. So therefore, all of us should note that one thing is the corticospinal involvement is characterized by spasticity with the initial resistance to the passive movement with subsequent release, what we call a clasp knife response. Right. Okay. Yes.
Sir. Power of the child. Power of the upper limbs, the shoulder abductors, adductors, and flexors extensors, the power was 3/5 with internal rotators and external rotators. Elbow flexion extension, wrist flexion extension was also 3/5. The hand grip was weak in the right side, but it was good in the left side.
What is the better method to assess the hand grip? How did you test? How did you test for hand grip?
I made the child to hold my hand, sir. Shake hand.
Shake hand.
See, and like he is supposed to.
See, the better way of identifying hand grip is give your two fingers, index finger and middle finger. Ask him to hold with his fist. Okay, don't give one finger, he may crush it. To give two fingers, he cannot crush it easily. So therefore, that is one way. Another way is if the child has got sufficient degree of movement, you can ask him to give a sphygmomanometer cuff and ask him to inflate it, the bladder, such that you can compare right side with its fellow on the left side. Right? In that way also you can assess the hand grip. So these are bedside methods you can make an assessment of the hand grip. So in this case, hand grip was weak on the right side and it was good according to you on the left side.
Yes,
okay.
Power of the lower limbs, the hip flexor, extensor, adductors, abductors, and knee extensor, flexor, ankle dorsiflexor, plantar flexors were all decreased. The power was 3/5. The left side was 5/5. Superficial, coming to reflexes, superficial reflexes, corneal reflex, conjunctival, abdominal, cremastic reflex were present on both the sides. The plantar reflex was on the right side was extensor response, on the left side was flexor response.
Just wait.
Yes, sir.
Cremastic is present. Plantar is extensor on the right side. So you have elicited. So what are the, did you elicit for any other reflexes? In the upper limb, you have tested for an extensor plantar equivalents.
Hoffman reflexor.
Did you elicit the right side?
I elicited, sir, but I couldn't get the flexion, sir.
No.
Some amount of spasticity.
Spasticity was there, sir, in that baby.
Okay.
So when there was a flexion of the middle finger, there was no flexion of the index and ring finger, sir.
Okay. So you have to elicit both. You see, most of the cases, there may be difficulty in eliciting the Wartenbergs, but Hoffman's, most of the times you can elicit. So there, you can get the response also in these children. Okay, right.
Okay, sir. Deep tendon reflexes, bicep jerk was bicep, triceps, ankle, knee jerk were exaggerated in the right side, is normal on the left side. Ankle reflex was having clonus on the right side.
So did you make an attempt to elicit patellar clonus also, right side?
No, sir.
So ankle, there is a clonus. That means 4+ is there. And how did you elicit for clonus for the benefit of postgraduates? Can you tell?
Yes. Yes, sir, I can tell. The patient is made to lie down in supine position. We have to flex the hip joint and we have to also flex the knee joint, and we have to support the ankle joint. We have to hold our hand at the knee joint, not the calf muscle.
Support the ankle joint.
Sorry, sir. So we have to support at the knee joint, and we have to hold at the knee joint, and we have to dorsiflex the toes, sir. And the forefoot.
You have to clasp, so you can grasp the forefoot, just extend the tendoachilles by doing dorsiflexion of the ankle. So if there is a sustained clonus, so where do you get that sustained clonus?
In case of a human type of lesion, sir.
Upper motor neural lesions get exaggerated. So it is a form of exaggerated ankle joint. Right. Okay. Yes.
Primitive reflexes, rooting reflex, palmar grasp and plantar grasp are absent on this child.
Yes. Sir, Prashant sir, you want to ask any questions?
No, sir.
Sir. Yes.
Ideally, she should mention like she has mentioned the position in the lying down, this one. Ideally, in such a big child, we should mention it as a gait, circumduction gait, right circumduction gait usually expected.
Yeah, she has not yet come to gait, sir. Now only she is telling up, I think. Just now she has projected gait.
Yeah. Okay.
Yes.
And there is no involuntary movements. Gait, circumduction gait on the right side, sir.
Yes.
Posterior column sensation, child is able to proprioception, 2-point discrimination. Proprioception and vibration sensation is present in the child. And pain and temperature sensation are intact, but the child is not able to, cortical sensation are absent, sir. Stereognosis and 2-point sensation.
You said above in the posterior column sensation, 2-point discrimination is present. And below you have
Sorry, sir,
mentioned
that's a mistake, sir.
there is a mismatch.
Sorry, sir, that's a mistake, sir. Sorry, sir.
So what are important cortical sensations we need to check for?
2-point discrimination and 2-point localization with and stereognosis, sir. We have to see for cortical sensation.
What is that stereognosis? What do you understand by that?
Stereognosis is when a child is given a familiar object. The child is supposed to close his eyes and given a familiar object to hold in his hand. The child is able to tell what is the object.
Familiar object you have given?
Yes, sir.
What is the object you have given?
We gave Eclair's toffee, sir.
Did you check?
I have checked, sir. We carried.
What is the object you have given? Do you remember?
Toffee, sir. Toffee.
Toffee is no doubt children are fond of it, but all the time they may not be identify it as toffee because they carry different shapes and sizes. So you would have given a much familiar object if the patient were to be able to identify in general a coin or something of that sort. Okay. Then what about other cortical sensation which is of important? What is graphesthesia? Stereognosis and graphesthesia are the two cortical sensations which require cerebral cortex. It is the finest form of sensation. So it requires sensory integration such that the person will be able to identify the shape of the object and also how do you test for graphesthesia? Any idea? Okay, right. Continue. Sridhar garu cheppandi.
Cerebellar function.
ఇప్పుడు వీడియో కాన్ఫరెన్స్ లో ఉన్న తర్వాత మాట్లాడతాను సార్ వీడియో కాన్ఫరెన్స్ లో రైట్ చెప్పండి.
Cerebellar function is normal. Microcephaly is present. The spine examination of the child is normal.
So there is a microcephaly. It is
చూడమని
క్లాస్ లో ఉన్నాను చెప్పండి. Yes. Okay, let me call. See, I don't advise you to make a posterior column, lateral column. I think that anatomical category, instead of that, simply make a mention about the sensations. So not necessarily lateral columns. Suppose what are the tracts that mediate the pain and temperature sensation?
Lateral spinothalamic tract, sir.
Spinothalamic tract. Where do they end usually?
Cortex. 312, sir. Somatosensory.
And that is final common path. That is final.
Thalamus,
at the level of thalamus. Suppose lesion at the thalamus can interfere with the even pain and temperature sensation. Is it not? So therefore, spinothalamic tract is one aspect and posterior column sensation. In general, when you are testing for the spinal cord, suppose the patient comes with a spinal cord lesion, a compressive myelopathy. In such a case, you can describe in detail about all the sensations. Right. In this case also, there can be possible, this being a stroke patient, with a possible capsular lesion, the sensory fibers, where are they located? In the internal capsule, where the sensory fibers are located?
Anterior limb, sir.
No,
posterior limb.
Posterior aspect of posterior limb. So posterior aspect of posterior limb will have sensory fibers as well as visual fibers. So that is the reason when the patient presents himself with a capsular stroke, you have to find out if there is a motor symptoms are there or not. Similarly, you ask for sensory symptoms and you also ask for the visual symptoms. Okay, apart from evidences for cortical deficit. Right. Continue.
Okay. Other system examination was normal, sir.
Okay.
Sure, sir. Shall I tell the summary, sir?
Yes.
11-year-old male child born out of second degree consanguineous marriage, second in birth order, with chief complaints of paucity of right upper limb and lower limb movement since 4 years of age, seizures involving the right upper and lower limb since 14 months, early hand preference noted, history of head injury at the time of birth, history of X-linked transfusion at 15 days of life, history of stiffness of right upper limb and lower limb with global developmental delay. On examination, microcephaly, right cortical thumb present, wasting of right upper limb and lower limb, tone increased in right upper limb and lower limb, exaggerated reflexes in right upper limb and lower limb with right ankle reflex clonus present, right plantar reflexes extensor response, gait is right circumduction gait with cortical sensations are absent.
Okay. So why there is a, first my question is, when there is, patient is having a clear cut upper motor neuron lesion, why is that he is presenting with wasting? Just I wanted to, what answer you shall give, just I want. This wasting is possible in neurologic lesions. I don't say wasting cannot occur. Here it is a UML lesion. In which lesions you come across wasting as a most striking feature?
In LMN lesions, there will be wasting, sir.
Right. Yes, very good. Why in LMN lesions it is the most striking?
Because of disuse atrophy.
That can occur with the disuse, can occur with UML lesions also.
Yes, sir, because
what is the explanation that is given? So the explanation that is given for LMN lesions having a marked atrophy or wasting is due to LMN is the final common pathway. It is the final common pathway. So all the trophic impulses, they need to pass through LMN only. Suppose if the trophic impulses are lost, early wasting is a most important striking feature and the hallmark of LMN lesion. If, for example, you take a poliomyelitis. So in these conditions, you come across wasting as a most important striking feature. So if there is, here it is a case of clear-cut case of UMN. UMN also in the long-standing cases, there is a possibility of wasting. That is one thing. So what are the other differences between UMN and LMN?
In UMN lesion, there will be spasticity, sir. When that have in LMN lesion, there will be flaccidity.
Very good. Flaccidity is another important feature. Flaccidity means hypotonia.
Hypotonia.
So hypotonia can be there right from the newborn period. Hypotonia can be there. A baby can be floppy. Right. Okay. Agreed. Then
the reflexes, they will be exaggerated reflex in UMN, while there will be diminished reflexes or absent reflexes in LMN.
So hyporeflexia or areflexia may be a feature of an LMN lesion. Yes. Anything else?
Clonus plantar response will be extensor responsive, while here it will be flexor response.
Yes. So this point is also important. You get a extensor plantar response. In fact, I say this is one of the most important evidences of UML lesion once it comes to clinical assessment. The reason being, you may come across hyporeflexia or areflexia and also hypotonia even in UML lesions during acute stage. During acute stage. What is that called?
Spinal shock, sir.
Stage of spinal shock. So therefore, that stage, if you assess the patient, you feel the patient has got some LMN lesion. But if you elicit for plantar response, you get an extensor plantar response. So it's stroke clinics, first 48 hours, 72 hours, if you look for the patient may have even decreased tone also. So that is one part. So these evidences of UML lesion may take time to evolve. And by the time, then before that, you can elicit for extensor plantar. Right. So anything else you want to tell about this summary? That's all. Right. Circumduction gait, cortical sensations are absent on the, okay. Sir, Dr. Prashant, sir, you want to ask?
Sir, just want to know, other than summary, are you going to tell your differential diagnosis at the end of the history, at the end of your clinical examination, and then after investigation? What are your differential diagnosis in this case, usually in any CNS case?
Yes, sir. Sir, shall I show the slides, sir?
No.
Sir,
Subramanian sir. Subramanian sir. There are good number of postgraduates are there. You can question. Vaishnavi is there.
Okay.
You can take VRN Reddy comments.
Okay, I'll give at the end some comments. I'll give some comments at the end. Okay.
Okay. Amma Sharan.
Yes, sir.
This being a human lesion, most possibly a capsular lesion, that is one possibility. What are all the ways in which a hemiparesis can occur? What are the sites at which it can occur? With lesion.
Sir, you are asking direct question only, sir.
Anatomical question. Anatomically speaking,
Level of lesions.
Level of lesion. That is more important. Anatomical locus, where the lesion can be. If the child is presenting with the right side hemiparesis, where all the sides the child can have a lesion.
Child can have lesion in the cortical region, subcortical region, internal capsule, sir. And also even the brainstem, midbrain, pons and medulla, and even the upper cervical, sir, high cervical.
Excellent. So therefore, you can have a lesion in the cortex, a subcortex, or a corona radiata, or it can be in the internal capsule, or it can be in the brainstem, or it can be the cervical cord. So what is the difference between the cervical cord lesion and other lesions? Suppose if it were to be a brain, could this be a brainstem lesion? Could this be a brainstem lesion?
Unlikely, sir, because in brainstem lesion there will be ipsilateral cranial nerve palsy with contralateral.
Very good. So it is called crossed hemiplegia. So brainstem lesion is characterized by crossed hemiplegia. Ipsilateral motor cranial nerve palsy with contralateral hemiparesis is called crossed hemiplegia. If it were to be brainstem lesion, because from 3, 4, 6, 7, 8, and all these things, if the nerves are involved. In this case, is it a possibility?
No, sir.
Could it be a cortical lesion?
It is most likely to be a cortical lesion, sir, since the child is presented with seizure also. So seizure, loss of consciousness is there. So more towards cortical lesion, sir.
Good. What are the other evidences of focal cortical deficit? One is seizures, as you said. What are other evidences that are there in this particular case to say that there is a possible cortical involvement?
There is microcephaly, sir, in this child.
Good. Yes.
So the brain development.
So there is an arrested brain development.
Yes.
Anything else? What is more important? What are the other clinical evidences of cortical involvement?
So spasticity is there.
Vaishnavi, you can
Sorry,
also
sir, I'm
add
not
points.
understanding.
Speech. You did not tell anything about speech. Is it not? Speech involvement usually indicates a cortical deficit. Is it not?
Yes, sir.
If it were to be involving a dominant hemisphere, of course, in this child, the child is left-handed because his right hand is handicapped right from the very beginning. Is it not?
Yes, sir.
Okay. So usually most of the left-handed individuals as well as the right-handed individuals, the dominant hemisphere is on the left side. And if the patient has got a left-sided involvement, most likely it involves the speech also. Speech may be involved. Whatever speech that is produced is usually a dysphasia, not dysarthria. Okay. So there may be, so he is able to comprehend your speech, but is not able to speak not more than few words you said. So the speech word content is less, vocabulary is less, but his naming and other things are okay. His comprehension is good. Okay. So if it is involving this one, suppose if there is other non-dominant hemisphere is involved, what will be the evidence of clinical evidence of cortical deficit?
There will be spatial the child parietal lobe.
Yes.
Sir,
what will it produce clinically?
Sir, spatially there will be child will not be able to
identify whatever are there on the left side.
Left side, yes. Hemi-neglect will be there.
So that is called sensory inattention. Sensory inattention or perceptual rivalry we call, because he will ignore on the left side of what he is having. Suppose your examiner is standing on the left side of the patient, you may ignore him altogether. What in terms of testing?
Dyscalculation. Calculation also will be impaired, sir.
Calculation work రాలేదు వీడు మాటలే 4-5 మాటలు వచ్చు వీడికి అందుకని నేను అనేది వాడికన్నా ఏం చేయొచ్చు మీరు సింపుల్ వాట్ ఈస్ కన్స్ట్రక్షనల్ అప్రాక్సియా because he's an older child I'm asking younger kid there are limitations I can understand he cannot draw a diagram so therefore he cannot assemble the parts and draw a diagram. So therefore, he will be finding it. Suppose you give him a matchstick and ask him to light a matchstick also, you will not be able to take out the matchstick, you will not be striking it. There are so many missing links. So
copying images. Copying images.
Yes. So by you can show him images and ask him to do, he will not do. Or you ask him to try a man test he will not be able to draw the limbs and head and trunk in the form of even sketches or lines also. Okay, so some degree of difficulty in assembling the parts of a whole, he finds it difficult, and it's called constructional apraxia. That is there in the non-dominant hemisphere. These are all possible in older children only, right?
Okay, sir.
So this is one thing we need to know. So in this case, there is no possibility, less possibility of a brainstem involvement. There is a possibility of cortical involvement because the patient is having focal cortical deficits, including a seizure phenomena. So in the absence of focal cortical deficits, can you rule out a cortical lesion? Above, there are no evidences. Still, you can rule out if they are absent. You must remember, if there is evidence, if there is a positive evidence for cortical deficit, you can say cortex is involved. In the absence of that, you cannot say that the cortical deficits are not there. Okay? So it is positively pathognomonic, not negatively pathognomonic, right?
Okay, sir.
Then what about internal capsule? Here internal capsule is a possibility, is it not?
Yes, sir. Internal capsule is a possibility, but the thing is, the child's sensory perception to hot and cold water is good, is there, present.
No, it can be, because hot and cold is pain and temperature sensation where it is mediated up to thalamus.
Thalamus.
So, you see, final cortical sensations you have to test for internal capsule. Cortical sensations, are they there?
Absent, sir.
Absent. So therefore, there is a cortical sensory impairment is there, and but usually in the internal capsule, all the fibrils are bundled up. So therefore, you get a dense lesion, right-sided hemiparesis, and there can be involvement of even sensory fibers. But internal capsule usually will be accompanied by what is another common accompaniment clinically?
Vision, sir.
Vision also may be there. Then apart from that, anything else?
Cranial nerve involvement.
Hemianopia may be there. Then apart
cranial nerve involvement.
Cranial nerves are in the brainstem. Internal capsule we are talking is higher up, above the brainstem. Internal capsule passes just by the side of basal ganglia. So therefore, there is a possibility of extrapyramidal involvement. Suppose you come across in the same patient some degree of rigidity. In the same patient, you come across some abnormal movements like chorioarthroid movements. So these are the things which you have to look for if there were to be a capsular lesion. So accompaniment of evidences of extrapyramidal involvement is more common with internal capsular lesion.
Okay, sir.
Most commonly missed one is the dystonia. So the child, as you can see in this photograph, I feel this child has got a dystonia also involving the right upper limb. So therefore, the persistent dystonic posture also speaks that child has got an extrapyramidal involvement. Okay.
So we had 20 more minutes.
Okay, continue. Right.
The differential diagnosis we
Wait.
Sir.
Sir, we are ready, sir. Your comments, sir. Unmute చేసుకోండి.
Okay. You know, very nice case presentation, and Dr. Subramaniam sir also discussing. Student also very nicely presenting. I want to tell you about 4 things. In any CNS examination, the problem for the students regarding the cranial nerve examination. So all cranial nerves, when you want to examine, start with history of the cranial nerve. Suppose if you want to olfactory, whether smell is good or not, like that, for vision is there or not. So any examination of cranial nerve, first history, then you go for the examination. Then as he is already discussing, in case of complete hemiplegia, internal capsular lesion, you may expect upper motor neuron type of 7th nerve paralysis, sir. Subramaniam sir, as you are telling that, is it? So, and 12th nerve also, it can be expected in upper motor neuron lesion, particularly when internal capsule is involved. That is called complete hemiplegia. That means hemiplegia is on the right side, cranial nerve paralysis also on the right side. Once you take the 7th nerve, only lower part is involved. Upper part of face is not involved because of bilateral involvement. And second very important factor when you want to examine up, show the prawning, students what they do, ask the patient put like this, they turn the head back and look up. That you cannot do. Look the patient, make down, and ask the patient to look up like this. This is the best way of examination for the prawning. But most of them students, what happens in tension, they pull the head back. So that's they cannot do. This is the best way you can do like this. And for that also, even simply doing like this and keeping one finger, ask the patient to look up. And coming 4 important nerves, I want to tell importantly, most of the confusion. We will start with the 12th cranial nerve. See, every cranial nerve, there are 2 cranial nerves. Once you want to put out the tongue, we got 2 tongues, right tongue and left tongue. When there is a right paralysis is there, the right tongue is not moving. So when you want to put out, right is not coming out. So left tongue pushes the right towards the right side. That means in 12th nerve paralysis, tongue is deviated to the diseased side. This is the reason. 12th nerve paralysis, right tongue is not moving, left tongue is moving. So tongue is deviated to the diseased side because this is not moving. When you're pushing out, tongue is coming out. And as already Stephen rightly said, next I will go for the 5th cranial nerve. As doctor was telling, the muscles of mastication, particularly pterygoid muscles, medial pterygoid, medial movement, lateral pterygoid opening. In a 5th nerve paralysis, again history, first you have to ask every case history, movements are there, achieving problem are there, then only you should examine. In 5th cranial nerve also, because of the medial pterygoid is involved on the right side lesion, left pterygoid is properly functioning, that will push the jaw toward the diseased side. So 5th cranial nerve, jaw is deviated toward the diseased side, and the 12th cranial nerve also diseased side. Coming to the 7th cranial nerve, when ask the patient, again history, important is ask the patient say E. Oh. So like that, that's kannu gattiga mooskora ani cheppali, kannu gattiga. Then if you ask the guest to open E, the deviation in the case of now everything is double. So now right 7th nerve paralysis is there. So right muscles are not acting, whereas left muscles are acting. Whenever you want to say E, so because left is acting, left angle will go up. In case of 7th nerve paralysis, angle of mouth is deviated toward the normal side. So better to say diseased side, normal side. Don't say same side, opposite side. There is only in assembly, not here. So jaw is deviated to the normal side in the case of 7th nerve paralysis. And one more important is the 10th nerve paralysis. Again, as already repeated, telling you, all are 2 nerves will be there. Whenever you say, oh, ask the patient to say, oh, then we got 2 soft palate. When the right soft palate is involved, right soft palate is not moving, but left soft palate is moving. It pull the uvula towards left only. That means in 7th nerve paralysis and 10th nerve paralysis, deviation towards the normal side. One more mnemonic I'll tell students. 10 plus 7 is equal to what, Stephen?
17.
17.
17.
One more is 12 plus 5.
17, sir.
17. And this way you start, because lot of confusion for the students. Tongue is very easy to start. 2 tongues are there. And in the next question, we'll ask the examination. In a bilateral paralysis of the 12th nerve, tongue is deviated to which side, Stephen?
No, sir, it is not deviated.
That you should say. In examination, don't say right side, left side. That no deviation. That's very good. All cranial nerves, both no deviation towards the bilateral lesions. And as already Subramanian told very clearly, see now there's again complete hemiplegia, crossed hemiplegia, incomplete hemiplegia. Complete hemiplegia means whole body and one of the cranial nerve, particularly 7th cranial nerve, upper motor neuron type is involved. 12th also involved, but it's very rare. So that is why it's called complete hemiplegia, ipsilateral hemiplegia, and that is the only one side. When anatomical lesion always above the brainstem, you remember like this: crossed hemiplegia, anatomical lesion, brainstem only, and cranial nerve involvement, whichever side is there, pathological lesion is on the side of cranial nerve involvement. Suppose I got a right 7th nerve paralysis of lower motor neuron type, my lesion will be on the brainstem, right side of the brainstem 7th nerve area. Crossed hemiplegia, anatomical location, brainstem, level of the lesion, side of the lesion, on the side of cranial nerve is involved. It is always associated with on the cranial nerve on the side of the involvement and hemiplegia on the opposite side. So this is the typical cross hemiplegia. Whenever you say complete hemiplegia, level of the lesion above the brain stem, internal capsule, corona radiata, subcortical, cortical, you can go above. And it is usually not associated with cranial nerves, not associated with cranial nerves. That is whenever you say incomplete hemiplegia below the level of brain stem, again lesion is on the side of the brain stem. You two things you should say: level of the lesion, side of the lesion. Complete hemiplegia above the brain stem, level of the lesion above the brain stem, side of the lesion on the opposite side. Cross hemiplegia, level of the lesion, brain stem, lesion, side of the lesion on the side of cranial involvement. Incomplete hemiplegia, level of the lesion below the brain stem, lesion on the side of wherever side hemiplegia is there. These are the important things, and all other things you have clearly mentioned, stereognosis and all this. And one more important thing, what I want to tell you, the confusion of spasticity and rigidity. See, pyramidal tract, the main action of pyramidal tract is only to stand and to start any motor activity. That's why initially you will have more rigidity. Whereas extrapyramidal system, basal ganglia is control of throughout movements. Every time it's going to and fro. That's why both groups are involved. Both groups of muscle coordination, fine coordination. That's why you'll get the rigidity throughout the movements, either cogwheel rigidity or lead pipe rigidity. So, but the problem here in the case of pyramidal, the action of pyramidal tract is mainly motor initiation of the movements and against the gravity. When animal is sitting, we have to stand. That's why all muscles, flexors in the upper limb, extensors in the lower limb, they are more tone is increased. And these are only things I wanted to tell. Okay, and anything else?
Yeah,
wish you all the best and very good congratulations for the student. Okay.
And one important point in the extrapyramidal involvement is appearance of involuntary movements. Not alone there is a rigidity. Involuntary movements is the hallmark of extrapyramidal involvement. So there may be failure of initiation of voluntary movement. And apart from that, some involuntary movement may be in the form of chorea, athetosis, or dystonia, some other form of movement disorder will be there. So therefore, whenever you are presenting, especially if you suspect a capsular stroke, always elicit for the appearance, history of involuntary movements carefully, and examine the patient also, because chorea and athetosis is often mentioned by the patient, but dystonia you have to observe. So if dystonia is there, that is suggestive of a capsular stroke. That point you remember. Similarly, in brainstem also, crossed hemiplegia don't take too rigidly. We have seen cases of brainstem gliomas presenting with bilateral cranial palsy also.
Oh, that is there. Hemiplegia, sir. Yes,
Brainstem is such a narrow.
What I wanted to make it clear to students, the brainstem glioma hallmark is bilateral cranial palsy. That's okay. But coming to hemiplegia,
there can be bilateral motor cranial palsy also, because the brainstem is a narrow structure. Suppose if there is a glioma involving the brainstem, it may produce cranial involvement on both sides. In general, most of the time, paralysis, ipsilateral motor cranial palsy and a contralateral hemiplegia is a feature of. And as sir said, in the cervical cord, the lesion is on the same side of weakness. It is not on the opposite side, because it is though it is a vertical lesion. It is the cervical cord left side hemiparesis is there, means there is a left-sided cervical cord lesion. So therefore, that is one thing you can remember. So just continue, Sharan. I think time is up. I should not expect of that. You continue. Yes.
Sir, shall I say the differential diagnosis, sir?
So here finally you postulate lesion at cortex, subcortex, or capsule, literal
cortex, sir, cortex.
Cortex. Okay. So cortex, usually one point here against cortex is you will come across either a faciobrachial involvement or lower limb involvement, but not both. Cortex is such a vast expansile premotor cortex is there. So if it is involving the middle cerebral artery territory, it will produce a faciobrachial. Suppose if it is involving the anterior cerebral artery territory, it is in the interhemispheric fissure involving the lower limbs only. So if there is a diffuse involvement, entire right half has gone means more likely when the fibers are condensed and is in the form of a compact form, if they are there as in the form of corona radiata or a capsular stroke only, you get that picture. These are the points in favor of a what we call an internal capsular lesion in this. But the points in favor of cortical lesions are the seizures and delayed speech. Right?
Yes, sir.
Okay.
DD.
Sir. Sir.
Show the DD.
Right spastic hemiplegic cerebral palsy, secondary to vascular etiology, sir, like perinatal ischemic insult or brain injury, that is neonatal hemorrhage, or the child is having congenital malformation of the brain.
Here, all of us should remember as pediatricians importance of giving vitamin K soon after birth. We have had cases of cerebral hematomas in the children who have not received vitamin K at birth. So this point kindly remember. In general, pediatricians have to remember because newborn has to bear the brunt. Right. Okay.
So shall I go to the investigation part?
Yes.
Complete hemogram, RFT, LFT is normal, sir. I would like to go to the stroke profile. PTINR was normal. Protein C, S, and homocysteine levels were also normal. ECG was showing sinus rhythm with normal rate. 2D echo and carotid Doppler showed normal study and waveform.
Okay.
EEG showed low focal epileptiform discharges from the left hemisphere, sir.
Good. That also is evidence of cortical. Yes.
Do we have the EEG pages?
No, sir.
No.
Patients.
Because in this case, no, ma'am, we need to rule out because this is a hemiplegia. Sometimes they may have the EPC, epilepsia partialis continua. We need to see whether it is because many relapses or frequent seizures. We need to see that. So if pages are not there, it's.
Yes, sir. To our wonder, this seizure episodes also started very late in life. Just
only 3 episodes.
1.5.
Only 3 episodes of convulsions. Overall, only 3 episodes of convulsions. Every 6 months, 1 convulsion. 9.5 years, 10 years, 10.5 years. Like that. Only 3 episodes of convulsion in the whole life of the history.
Ravikumar garu, our people have observed. Our people have observed child throwing any convulsions, or it is only the history.
No, sir.
Hello.
In hospital stay also, the child had convulsions, sir.
So why? Because of sometimes what happens is the torsion dystonia or some dystonic posture by the child is labeled by seizures by the unwary parents. So actually there is a possibility of extrapyramidal involvement on the one side, left side. That would have made, you said the focal convulsions were involving the right side, whether it was some dystonic movements that were mislabeled by the unwary parents as seizures is my doubt. Because I postulate more a possibility of a capsular stroke in this lesion, in this case, right? Okay.
Okay, sir.
Yes, continue.
MRI brain showed hemiatrophy of the cerebral parenchyma on the left side with ex vacuo dilatation of the occipital and occipital horns, a relatively loss of volume of midbrain on left side, hyperostosis of calvarium noted in the frontotemporal region with widening and decreasing in signal intensity of the bone, flare intense, hyper intense signal noted in the white matter of frontoparietal lobe, gliotic changes noted. This is the MRI image, sir, of the patient. Sir, here we can see that there is a fluid filled. Fluid is also filled. And there is
But this is secondary to atrophy, no?
Yes, sir. This is secondary to the hemiatrophy.
Cerebral atrophy.
Yes, sir. This is secondary to the cerebral left hemisphere atrophy, sir. With there is also
hypertrophy of the contralateral hemisphere.
Yes, sir.
Yes.
We can see that.
Particular syndrome, think of like, that's where I was asking about the EPC. In this MRI picture, we expect epilepsy partialis. Sometimes parents may mistake, but in your case, obviously, as you said, only 3 episodes in a 6 month. Not significant, but usually we find out such kind of MRI picture with EPC on the right side.
Yes, sir. Here we can also, since it's an MRI, here we can also see that there is thickening of the left side of the cranium, sir. Hyperostosis is also present here.
Yes, yes.
This features
That
are
was
likely
the earlier findings, sir. Go ahead, Charun. I'll tell later.
So this is the features likely of Dicey-David of Mason syndrome. This is the MRA and MRV of the child. This also showed narrowed caliber of all the segments, like A1, A2 segments, P1, P2, and even narrowed caliber of C7 segment of internal carotid artery. This is my final diagnosis, sir. 11-year-old immunized child with right spastic hemiplegic cerebral palsy secondary to perinatal ischemic stroke with left hemispheric epilepsy with grade 3 PEM according to IAP classification with global developmental delay with gross motor function classification grade 1, manual ability classification system grade 2, and communication function classification system grade 3, and eat and drink ability classification grade 1. Radiological findings suggestive of Dicey-David of Mason syndrome.
So, do we need to add anything to in this final diagnosis? Obviously, you have mentioned epilepsy is one of the comorbidities secondary to the cerebral one. Any of the associated comorbidities you need to mention in general when you are mentioning the cerebral palsy?
Sir, hearing with no visual and hearing impairment, sir.
Yes, yes.
No,
Any
sir.
Ram, can you read out the MRI report of this child?
Yes, sir. This one, sir?
Not MRI, angio, MRI. Yes.
MRI angio.
Hemiatrophy of the cerebral parenchyma on left side with ex-vacuo dilatation of the occipital horns, relatively loss of volume of midbrain on left side.
So we can expect, some loss of midbrain can be expected once there is the atrophy of the cortical matter. Because the descending fibers have gone, naturally you can expect some degree of reduction in the size of the midbrain also. But my doubt is whether the child who have had possibly a hematoma, extradural hematoma in the neonatal period could have caused all these problems because of pressure atrophy of the brain, but there is something like a reduction in the size of the cerebral hemisphere on the left side. It's an acquired insult. Yes. Why we want to fit it into one syndrome? If we're going by imaging, I agree. Radiologists may be of opinion that it is maybe that syndrome. But in this case, there was a clear-cut case of head injury. Child had a case of cerebral hematoma, had jaundice and exchange transmission and all. And subsequently, child, as per your history also, there were all early markers of CP were there on the right side. So possibly this child had a cerebral insult because of hematoma, because the child had sustained a head injury. Is there need to fit into one syndrome or not? Is my question.
Sir, this syndrome is a radiological, more so of a radiological.
Radiological description.
Description, sir.
Description. But here in this case, the cause is very obvious. Child had an intracranial problem, an intracranial bleed, because of which there is a cerebral atrophy. Consequent to that, there is a hemiplegia on the right, chronic hemiplegia on the right side with early childhood onset. That I would be my clinical diagnosis.
Yes, sir.
Right. Sir,
one more question.
Hello.
When do we send the coagulation profile in hemiplegic? Obviously not in this case, but when you come across either right or left hemiplegia or hemiparesis, rule out this protein C, protein S deficiency? When do we send the protein C, protein S or coagulation profile?
After 3 months, sir. After 3 months of the incident.
Okay. In this case, to pardon?
Sir?
Before transfusion of any blood products.
No history of transfusion.
So the so-called hypercoagulable states like presence of protein S and antithrombin 3, all these things can be there as a primary defect, or they can be secondary to some other problem also. Like sometimes it can occur in conditions. We had one case here in our ward also, a child with a connective tissue disorder presenting with hemorrhagic bilateral pleural effusion with a stroke. So therefore, we need to evaluate the child for any hypercoagulable state also, where the part of stroke work, right?
Yes, sir.
Sir, here I want to tell two things, sir. Hello. Because here there is a some amount of negligence from the pediatrician at the time of birth, because child when has come with a history of head injury and child gone for the extent transfusion and gone to the neurosurgery, neurosonograph, all this has been done. From that time onwards, we should have followed this case very meticulously. That is the one point. We could not fail in counseling the parents to come to the doctors. So this is one, just there is a lack. Of course, we would have not done anything. Maybe before 2 years, some amount of brain protection, we would have done it. And second particular point is, both child is having a massive atrophy. The other part of the brain has been well developed. So that has been taken most of the part, so that the child nearly looking normal for the parents. Though there is a clear-cut deficiency is there, obvious deficiency, not able to walk, they would have rushed to the pediatrician. So because there is some limping walk or some delayed walk and delayed speech or something, it is there. All are delayed, not absent. So that has also not brought the child to the. So as my nursing ladies are said, you only said vitamin K in this type of case, it is a high risk case. 100% it is indicated. So this is one part, as you said, it is neglected because so much hematoma must have caused, and that has been formed into the cyst, and finally it is necrosed. The whole brain tissue has been necrosed. And Ramdasan lady, sir, it is like a baker stuff.
Hello. 1 minute. Hello. You know, very nice case. I want to say only one thing for postgraduates. See, in examination, history and physical examination, two things are very, very important. History means it is a story. Its spelling is history means story. It will tell the story of the disease process. It will tell the story of the disease process, and the disease runs always over a period of time and is always constant. So regarding history, 3 points you should remember. It will tell the story of the disease process. It will run over a period of time and is always constant. It's always constant. So, coming to the physical examination will tell you about the condition of the patient, at the given point of time. It is a given point of time that is very, very important, and it's always variable. History is always variable. That's why we ask postgraduates to look the case as many times as possible. They think that SARS always tells like this only for us. And I now one more important point that Subramaniam raised in the diagnosis. The 3 things are here. One is patient, second is physician, third is investigation. Who is right? Patient is 100% right always. Patient is 100% right. Second, 90% physician. You can take only 80% is investigation, as Dr. Subramanian clearly mentioned. Don't believe investigations. Always look at the patient. Look at the patient, listen to the patient. He is always right. Next, VR. Third is the investigation. That is one important point brought in this example diagnosis. Don't go with impression of investigation, because clear-cut history is there. As Ravi also saying, we are hearing from the beginning. In reality, we should not take in this forum, but it is 100% our negligence. What,
Thank
Ravi?
you, sir. Thank you, sir.
Vitamin K as a bottom line, which is very important to give vitamin K, especially as Dr. Ravi Kumar said, in the traumatic labor, precipitate labor, and the mother is on drugs like AEDs and also, for example, anti-tuberculosis. So in these settings, there is a must. The child should receive vitamin K soon after the birth.
Yes.
So if it is not given, it can lead to serious issues, which is easily preventable. I think we need to pay attention to this. I don't say someone has not given this child, but there is a possibility. So we must be very careful and vigilant. See that child gets the benefit, because vitamin K.
So that is
mother's milk
that
is
is
a
only
poor source of
possible.
vitamin K. Mother's milk is a poor
That is
source of
only
vitamin
possible.
K.
Okay, one more thing. Even all the either
that
Dr.
is
Ravi,
possible
1
in the
minute, 1 minute.
post-graduation.
Either Ravi told and Dr. Subramaniam says,
Yes, sir.
always try to diagnose a treatable condition. Is already diagnosed. Always try to treat the condition rather than waiting for it, because never try to miss the diagnosed condition. Here, 100% the diagnosed condition is trying to miss every time. So always we should never try to miss a particularly a treatable condition. That is a very, very important, good lesson in the child, as that Ravi mentioning. Okay, Ravi, over to Ravi.
Sir, in this, sir, lastly, 30 seconds. This provided if they learn today, tomorrow they cannot neglect like this. So I request everybody to learn like this. That is one point. And Subramanian sir points are very well taken, because it shows his tremendous interest towards the neurology. And Ram Narasimha Reddy sir, the neurology part, either the convulsions or neurology science, it should be some amount of mind should be there, mind. So action should be there. So you have done demonstrated with that mono action. That is mandatory to students to understand. So you were demonstrating with mono action. Excellent. Today, I want to appreciate you for your mono action also, sir.
Sir,
Thank you, Sridhar.
Sir, I request GV Subramanian, any final remarks?
It is a wonderful presentation by Dr. Sharan, and thanks Iaptcb by providing a good platform for all the young postgraduates to learn something new every time they conduct a session like this. But my message to postgraduates is pay utmost attention to history and clinical assessment to arrive at a clinical diagnosis first, and anything should be supplementary. I don't undermine the importance of imaging and others, but if a clinician has got the lead to proceed with the investigations, that would be better. So with this few remarks, I thank all the people for giving me this opportunity.
Prashant.
Okay, 1 minute. Lastly, 1 minute. Hello.
Closing remarks.
Subramaniam says history is always, according to me, history is 90%. Subramaniam sir, history is 90%. Physical examination 9%. Investigation only 1%. This is the way postgraduates should think to act, because they should don't think that history is no use. History is 90%. Physical examination 9%. Investigation only 1%. This is the starting point for PGs. Okay.
Prashant, closing remarks.
Yes, sir. It was a wonderful case presentation, and definitely, as both of your respected seniors said, history is the key factor where you get the diagnosis. Investigation or your examination is just to confirm the diagnosis. That's it.
Yes.
Yeah. Now our coordinator Sirisha, please give the closing remarks. Then we can go for vote of thanks.
Yes, sir. Thank you, Dr. Sharan, for the wonderful presentation, and Dr. Ravi Kumar for moderating the session. And my one question to Prashant Uttage, sir, the difference between the subtypes, congenital and acquired subtypes of Dicey-Davidoff, and why epilepsia partialis continua is not there in this case. That one enlightenment the PGs need.
In this case, it may not be like in every case they present with, but if you see the natural history of the, as it is a radiological diagnosis, you'll be able to see they will get the episode of seizure from beginning itself. Okay, like from infancy. So seizure will start from infancy, and continuously I would have shown the, I was not sure this was only right hemiplegic cerebral palsy. I would have shown the 2 videos where there is a congenital malformation and this child has developed with the EPC. And in this case, maybe the it's not from beginning, so not started in the infancy. It is only, I think, last 14 months they have observed it. But ideally it is expected but in congenital malformation, definitely it is from the beginning, it is expected.
So it is, in this case, it's more of a hypoxic or traumatic result that has occurred after birth, perinatal. So this is coming under acquired subtype, and that is the reason this child is not showing seizures since childhood, like epilepsia partialis. And also the future of this child could be the classical atrophy of a face and the body is not very evident. He's still in the growing stage, isn't it, sir?
Yeah,
once
yes, ma'am.
Fully grown adult.
Pickup of the early cerebral palsy or early attendance would have changed the future of this child.
Yes, yes.
Thank you, sir. Now I request Lakshman Garlapati, sir, President, closing remarks, sir. Sir, unmute, sir. Unmute, sir.
Thank you, Dr. Sridhar. It was a wonderful presentation by Dr. Sharon and her team, Vaishnavi and Monica, under the guidance of Professor Dr. Ravi Kumar, sir. And this is the first TCB case. It's a very, very, very wonderful case. Whole neurology has been learned by all the participants today. And excellent moderation by Dr. GVS Subramanian, Professor, sir. And also tips from Dr. Narasimha Reddy, sir, though he joined little late. And also wonderful.
No, not late. I was there from the beginning.
No, sir.
I am the first person to join. Not, not you.
Don't comment, you will take
sir, but your comments for it for the last 15 minutes only, sir.
Okay, but presence was there.
Yeah, yes, sir.
He gave space to the actual experts, that's all.
Thank you, Dr. Udaje, and very well coordinated by Dr. Sirisha. Thank you, one and all. And I request Sirisha and all other Ravi Kumar, sir. So we are having 200 to 300 postgraduates in and around Hyderabad, but today's attendance is only around 70 to 100, around 100. I need more.
They are my candidates.
Yeah, yes.
And my candidates also there, sir. My candidates.
Sir. So I request all the head of the departments who are working in the teaching hospitals, please motivate all the PGs to participate in these programs, because these programs are being conducted by TCB with a lot of difficulty. General Secretary and me and Treasurer, we are all taking so many hardship to coordinate so many faculty members. So kindly take this into action, sir. Ravi Kumar sir and Sirisha madam and Ram Narasimha Reddy sir.
Yes, we are already in every time. I always instruct my PGs.
Sir, next PG program we should have 200, sir.
Okay, done.
So thank you, Lakshman sir. And before giving to the Sri Krishna for vote of thanks, one announcement: there is a ECD Early Child Development Workshop in Nilafore on 29th afternoon 2 to 8, precedes by lunch, and excellent book, ECD book will be given for all the participants. So already 25 participants are enrolled, only 15 left. Please tell your postgraduates and practitioners to enroll themselves and register by the Google form, which was circulating in the groups and mails also, personal mails also. Kindly and make it a grand success, the ECD workshop on 29th afternoon at Nilafore NATCO 4.
But Warangal also, there is one more workshop in Warangal.
Yeah, I know that, sir. That was a pediatric intensive care chapter.
Yes.
So now I request Sri Krishna RSV to say vote of thanks.
Thank you, everyone. First of all, let me inform everyone the kind of efforts which the new General Secretary Dr. Sridhar has put in. It takes a lot of effort to put something together, and all credit to Dr. Sridhar and the guidance of our President, Dr. Lakshman sir. We're very fortunate that we had our past President, Dr. Sankoch Bhaskar sir. Seeing him on the Zoom session was like reliving the last year completely, wherein every weekend we had something or the other to do. So it was a very nice experience. Thank you, Sankoch Bhaskar sir. Central IAP members, Dr. Arjun, Dr. Nirmala madam, Dr. Argal Bhaskar sir, thank you for the continued support, and I hope we'll be able to have more of Central IAP programs in the future, and we thank you for all the support for that in advance as well. And coming to the session, extraordinary session, very, very, for those who are not daily interacting with these teachers, this is probably the only way in which you can listen to them, only way in which you can hear them. And most likely they may be your examiners also when you finish your when you go for your practical exam. So IAP-TCP has its mission that we are going to have one PG clinic every month. And thank you immensely, Ravi Kumar sir, GBS Subramaniam sir, and of course the young and dynamic Prashant, who has added a lot of flair to approach to neurology topics. And my thanks to also our AB member, Dr. Sirisha, for excellently coordinating this. And the one who has benefited most is the one who has presented this case. Dr. Sharon, it cannot get bigger and better than this. In the exam, I can assure you this will be as good as this. And if you can perform as well as you have done, you probably get distinction for the kind of response that you have given. At no place were you really scared or did you show any mistakes which are unpardonable. So this video will also be available on YouTube for later viewing. I request you all to please share it with the others as well. All IAP-TCP YouTube videos have more than 500 views. So please share it with others. It will be very, very useful. This will stay in our library forever. And please join us for the ECT workshop. This year, last year we did 9 workshops. This year, probably 5 or 6, not more. And this is one of the very few extremely effective workshops. Only workshop where you get a dedicated book, not 1, but 3 books. Only workshop which is hands-on. There's no presentation. So please join for the workshop and we'll see you all again in a week's time. Thank you, everyone.
Thank you. Thank you, one and all.
Thank you. Thank you. Thank you.
Shabar.
Thank you, sir.